He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome, folks, to the Stay Off My Operating Table podcast with Dr. Philip Ovadia. We have today Dr. Lori Calabrese, who, you know what, I'm not going to say anymore. Phil, you'll do a better job of introducing her. I'm going to sit back and enjoy this one because I love this topic. That's all the teaser I'm
Awesome.
going to do.
Yeah, so am I. Real great to finally have Dr. Calabrese with us. She is another one of the trailblazers, I'll say, in this really somewhat new field of metabolic psychiatry. And we've had a couple of guests on, although it's been a while since we talked about it. Yeah. There's been a lot of exciting developments around it. And so really looking forward to this conversation. Lori, why don't you just start, let's hear your story, how you got interested in psychiatry, what led you to metabolic psychiatry in particular, and that'll be a great place to start the conversation.
I think it goes back to medical school. I never thought I would be interested in psychiatry when I was in medical school. And the docs that I met when I was at Hopkins, who were on the psychiatry service at the time, were so brilliantly across so many fields, bright and enthusiastic about psychiatry, neurology, and general medicine. And I thought, well, these are the smartest guys I know. I want to be like them. I want that kind of like broad everything. I want to understand the brain and the body and make it all work together. And so I pivoted. I thought I was going to become a pediatric cardiologist. That's what I went to medical school thinking I was going to be in it. So it was like a big pivot for me. Loved it, have been in the field ever since as a psychiatrist in a number of different settings, but really for the last more than 20 years in office practice. So that's been general psychiatry office practice until I really got so interested by something that happened with a patient. I think that's often what happens. I saw someone who came to see me who wanted a certain kind of treatment, but I didn't think that treatment was going to be appropriate for her because I think she really needed her brain to be better. And so she had started on a ketogenic diet just for a couple months. We weren't sure exactly where that was going. I gave her a few other treatments. And this young woman at the time with severe chronic enduring anorexia nervosa that nothing had touched went into full remission for the first time after being sick for 15 years. That meant she woke up one day and she called her mom, and her mom called me and said, my anorexia is gone. And so the mom called me and said she's had a couple of ketamine treatments after this ketogenic diet. And I said, I've never heard of that. I've never heard of that. I don't know if that's true. What should we do? She did another treatment, and then she stayed in full remission without recurrent intrusive thoughts and without any of the behaviors that had wrecked her life. She stayed in full remission for a year. And what happened was we wrote up that case because it was such a striking case report, got tons of hate mail from the world of eating disorders saying, how could you do something like this? How could you even suggest that a ketogenic diet could be helpful? And then went on to do a pilot study. I'm not a research investigator. I actually wrote an IRB, got it approved, put it on.
IRB.
An IRB is special permission to do a research study by an investigational review board. So they review the appropriateness of that and make sure that patients are protected if they're entering into a clinical research study. During COVID, we found 6 women from across the country with similar histories and said, we don't know if this was a one-off thing or if it's replicable. We'd like to do the exact same thing, put together all of the same parameters and see, would you be interested in doing it? Would you like to participate? We did this during COVID. They came to us with a support partner and basically lived with us for a long weekend and got ketogenic and then got treatment. And we went on a year later, we followed them for a year and published that. And that publication sparked a major funded randomized controlled trial, now looking at the first part of that in ketogenic therapy. So this is going on too long, but I'll cut to the
No, it's really not.
and
No.
say,
Yeah, it's amazing.
yeah, what
Um,
changed everything? Oh, sorry, Phil, I cut you off.
No, I was just going to clarify. You're using the ketogenic diet with other treatments?
That first time I did, because the problem was we didn't know what the signal was. Like with the ketogenic, nobody knew, because this was way before anything had come out anywhere. And I was thinking something really happened with her. She got 40% better before she had this follow-up treatment. I wonder how much better she would have been if she had done a ketogenic diet for 2 months instead of one. Wonder like what it takes. Was she measuring ketosis? What were we doing even? We didn't know. So this was all totally coming from the excitement of saying something that we never thought could shut up in the brain. And all of a sudden she got like brain space back. And it got me thinking, there are so many other times when people's minds are just sort of intruded upon by panic, anxiety, OCD, all this depression. Would this work for those things? So at about that time, at about the same time that we just got ready and published this, and Chris's book came out, Chris Palmer's book, Brain Energy, came out. And I thought, this is exactly what I've been seeing. I've got to do this. Nobody's doing it anywhere. People are interested in reading about it, but nobody's actually doing it. So that's what I started as a whole arm of my practice, a whole service designed to say, I can give you the standard psychiatric stuff, but if you're interested, there's a whole way we might be able to work with you introducing a ketogenic diet, really doing it meticulously, starting it as a registry, trying to figure out like what the signal is, because here's what was going on in the field. Everybody was saying, oh yeah, I've seen this in patients. And my thought was, yeah, then show me. Show me where it is. Show me where you published it. Show me what you did. Don't just say, I'm getting good results. So that's what I set out to do, was to like really see. And we published at the time a case series when we first started looking at what really walks into my office, which is complexity. So depression plus all these other things under the sun, right? Anxiety, panic, eating disorders, binge eating, ADHD. Like people don't walk into a psychiatrist's office with something simple, just like they don't walk into your office really with anything like ever simple. Is it ever simple? This case series had 3 adults, we were all different. They all had major depression. They all had generalized anxiety. They all had at least 2 other anxiety disorders, and they all had ADHD. And what we did was said, let's see what happens if we really add a ketogenic diet to what you're doing, because what you're doing isn't working. Now, otherwise, you wouldn't be coming to me. If what you were doing had worked, they had all been symptomatic for years. And then we started and really helped them do it with all different kinds of ways. And what we found was really profound, because we saw complete remission of major depression in as little as 7 to 12 weeks. Completely. It went away. It was gone. Their scores went not just to remission, but to 0. We saw complete remission of generalized anxiety in people who had never responded to that before. And we saw improvement in parameters and metabolic improvement. And one of these 3 who like amazingly achieved perfect metabolic health in 12 weeks. I wrote it up. So here's my like little side gig. I thought, I'm going to write this up as a case series. It wasn't a funded study. It was just the truth of what I saw. And when I wrote it up, that little case series, I call it my little case series, has gone on to become one of the papers within the top 5% of more than 26 million papers ever read, ever searched online, scientific papers ever read online by Altmetric. It's sort of gone everywhere. And it got me so excited about thinking, I need to stay meticulous. I need to see where the signal is. I want to sort of tell the story of what I'm seeing across different places. And that's how that started. And it's gone on to other things, OCD, ulcerative colitis, and then of course this story that I brought to the meeting where you and I met at the Society of Metabolic Health Practitioners.
Yeah, amazing
Real quick,
stuff.
just a point of clarification. What do you mean by the signal? You're using it in a way I don't understand.
The signal.
Yeah, you said you wanted to, it wasn't clear what the signal was. In context, it sounded like what you were describing was maybe the root cause, or
No.
why is ketogenesis effective? That's what I think I heard you say.
I was interested in, I was interested in whether or not the psychiatric symptoms that we know, identify, see, can actually go into remission and stay in remission.
Okay.
That actual rating scales, the actual sort of truth of it. And what would it take in terms of ketosis? What would it take in terms of ketone levels? What would it take in terms of other interventions? How do we do this with people? How do we monitor it? And what's the truth about how long it takes? So I wanted to look at all of that and just follow it along with all of the different things that we brought to play with people in our practice. So this wasn't go home, do it yourself. No, this wasn't
Gotcha.
like try it on your own. This was actually what we call ketogenic metabolic therapy, where we calculated the ratio, where we wanted to get it right, where we said, hey, Jeff Volek says ketosis happens at 0.5.
Yeah, so just to highlight something about this experience, you had been in practice for, 2 decades roughly, right? Before this happened, before, you saw this young lady. And, all of the treatments that you had used during, that, whether we're talking about medications or we're talking about psychotherapy, right? All of these things that you have available to you as a practicing psychiatrist. Had you ever seen true reversal of, pick a condition? Anorexia was the first one that this occurred in, but any of these other conditions that you've now seen reversal of, had you seen that at all before in your practice?
I think we are very clear about looking at things going into, we call it remission, right? When symptoms drop to a certain level. The issue is it doesn't hold often. It doesn't hold. So you can give someone a medicine, do a course of psychotherapy, they get better, then they're often told that they need to stay on this medicine because the things that they have tend to come back. And we see that when medicines are tapered, when psychotherapy stops, when life happens, they don't have anything that holds them. And it seems very much for many people that their symptoms fire randomly. At first, they might develop a symptom because something happens, or they might develop a condition. Something happens, brings it on. And then all of a sudden, it develops a life of its own and keeps going. What was so interesting about working with ketosis and ketogenic therapies with people and really working with metabolic strategies, I'll call them because there are many, is that I felt like I was giving people for the first time a chance to do something with their own hands, to actually do something other than waiting for me to minister unto them or waiting for someone to minister unto them. They could actually say, wow, I've got the power to actually settle my own physiology. I have the power to be resilient in a way that I have never been resilient before. I've got the power to maybe taper my medicines and get a kind of clarity I never had before. That just blew up. It blew up because it's so exciting for people who've struggled.
Yeah, I mean, and again, we see this right across the medical spectrum, right? When we're talking about these diet and lifestyle based therapies, that is what's so powerful, right? That you're giving the power back to the patient. They are in control. They figure out on a daily basis what they're going to eat, what they're not going to eat, what they're, all the rest of it that goes into it, exercise and things like that. But like you said, they're no longer dependent on the healthcare system, the physician, to, administer the treatment, like you said. And, I think that's amazing, right? It's also maybe why it's a little bit scary to the mainstream medical system because it really is flipping that model.
It flips the model because it does something that the mainstream medical system doesn't do. So I want to be clear about that, because I'm not saying that the model should be do it yourself, actually, in psychiatry, because there's so much at stake. So often there's so much at stake. But I do think it gives us a whole way to understand the way the brain fires and the way the brain signals. And the fact that there is this incredibly complicated loop between the gut, the brain, the sympathetic axis, that all of a sudden totally works in this beautiful way to settle things down. And, I saw that in the case report that we did around OCD, where OCD went into remission. And for the first time in this woman's life, her ulcerative colitis went into clinical remission. Like, it stopped at the same time over 12 weeks. And I said, oh, good. Let's go get a colonoscopy and now prove it. And she said, I'm not going to pay for the copay on a colonoscopy. I know that my symptoms are good. Why do I need to go do that? So it's just, exciting to see.
You started kind of alluding to, right, understanding why this happens. Much of the field of psychiatry and the treatment, of psychiatric conditions focuses on certain, chemicals within the brain, right? Serotonin and, other, signals. And, a lot of the pharmacology in particular is directed towards, okay, if we just balance out or alter, the level of this versus the level of that, that's going to lead to improvement. How does the fact that, metabolic therapy works kind of, change that thinking a little bit, or what does it kind of more direct us towards as the root cause of these problems to start with?
It flips it on its head. It flips it on its head. What we're really beginning to understand is how intricately what's happening in the brain is controlled by mitochondrial behavior and mitochondrial health and mitochondrial response to the fuel that it's fed. And so what we're really moving toward is this beautiful understanding of the interplay and the interconnectedness of the brain, the body, and the energetic systems and the signaling systems towards health and longevity. But they begin at the level of fuel, not isolatedly with neurotransmitter mechanisms. And now that we're looking at that, it's almost once you see it, you can't unsee it. You see it, and and then all of a sudden it sparked like incredible interest in research around the world, looking at what do we do? Why does this work? How does the signaling work? Where do we see this? Not just in psychiatry, in neurology and neurodegenerative diseases and Parkinson's, ALS, dementia, like across the board. There's such an interest in understanding the underlying mechanisms that drive this. So it's brought together people like basic scientists and clinical researchers and people who work with mice and people who study humans to talk like all together in this way that is really moving the field forward, really exciting for all of us. And I think even the fact that we're talking, I'm a psychiatrist talking to a cardiac surgeon about this. So incredible. It's this incredible, beautiful crosstalk that's populating a whole level of inquiry, like really populating a whole level of inquiry with questions that nobody used to ask before.
Yeah, what's interesting to me is how it really brings us back to the origins of, ketogenic and metabolic therapy, that, the first real disease state that was applied to was a neuro condition, epilepsy. And, I look back and, you said, questions that were never asked before. The way that I look at it is they were questions that were asked and then we forgot about it. And now we're rediscovering all of this. And again, it goes back to the roots, right? And before we had all the fancy testing and everything that we can do today to understand, like you said, the biochemistry and the mechanisms, it was figured out over 100 years ago, right?
Mm-hmm.
People with seizures got better when they ate a lot of fat and very little carbohydrate. It's just really fascinating and groundbreaking stuff. I guess, what that leads us to the question of, how widely applicable do you think this is within the psychiatric space? It's interesting within the cardiac space, right? I can go back to the work of Dr. Kraft, who showed that basically 90+% of patients that had atherosclerotic heart disease had insulin resistance if you knew how to look for it and tested for it properly. What is your sense, and what, maybe hard data do we have around how widely applicable this is to the psychiatric field?
Well, we know that there is a bidirectionality between insulin resistance and major depression, between insulin resistance and major mental illness, schizophrenia.
By bidirectionality, you mean?
Meaning they are connected, and we see, and they're linked. We see an association that is strong. It's a strong association across many different psychiatric disorders, and we need more research looking at this now. What that means is that we need to do the deep work to figure out where's the chicken and where's the egg, what caused what, right? And I think some of the early studies looking at, for example, medicines like pioglitazone, improving depressive symptoms, using a medicine that's typically used in diabetes and seeing, and the depressive scales got better, it was early, prompted some other studies. But to move to right now, when I look at how widely applicable is this, what I can say is among my network, there is research interest going on in most of the major metabolic, most of the major psychiatric disorders, looking at the connection now and looking at the potential for ketogenic intervention for example, in alcohol use disorder, in PTSD, in OCD, in eating disorders, in major depression, in bipolar disorder, in schizophrenia, it's in autism and autism spectrum disorders. So it's really scanned the gamut because, in fact, there are similar mechanisms that sort of are at the heart of this that create differential firing, that is responsible for what we think are the symptoms here. And we need a lot more research to clearly look at causation and how to fix it. But I think the research starts with people who start seeing the changes and then ask for researchers to now go looking.
Yeah.
Right?
Yeah. What do you mean by differential firing?
What do I mean by firing?
Differential firing, you said?
What I mean by firing is you can think of, for example, panic attacks as something firing to put off a whole series of cascades where the heart races, cortisol spikes, people get short of breath, and the panic takes over, right? You can think about seizures firing in the same way with a motor action that goes on. You can think about mania firing because something happened that turned on. Fast thoughts, appetitive changes, energy, staying up all night, talkativeness, right? You can think about psychotic symptoms firing because they don't happen continuously, but they sort of fire off. All of this firing means that neurons are actually firing.
Right.
To produce this.
Right.
OCD. What is it that gets the loop going and that then keeps it going, right? If we can stabilize that action, if we can stabilize and reduce the likelihood of neurons firing when they're not supposed to, when we don't want them to, when it doesn't serve us, then all of a sudden what you see, and what I've seen actually in the cases that I've reported, is resilience improves.
Makes sense.
Yeah,
For
resilience
sure.
improves. People just feel better overall.
Okay.
It's such a interesting, time with all of this, right? Because at the same time that, all of this work's being done around, ketogenic metabolic therapies, we have another sort of pathway that leads us to the same conclusion. We have, these GLP-1 medications that have become, widespread. And it turns out that they, in many ways, target the same pathways. They improve insulin resistance, for instance. And, while they started again as diabetes and then obesity medications, I am aware of a number of neuropsychiatric conditions that are being investigated as to their benefit and, kind of incidental, right? People just started noticing my depression gets better, and various other things when they're taking these medications for other reasons. I'd love to hear your perspective on that, how that's really leading us down this same metabolic pathway.
So I have a couple of different thoughts about that. One is I've seen patients on GLP-1 inhibitors who really benefited from them, both in terms of body composition and improvements, and who've had issues with side effects and things with them. And I think the metabolic pathway looks similar on the surface, but is wildly different underneath, right? Is wildly different. Why? Because there isn't anything like beta hydroxybutyrate. There just isn't. And you're not going to get that from a GLP-1 that allows you to still eat cookies and lose weight, or to still have pancakes and lose weight. And so what happens with that particular molecule, what it does, how ketosis ultimately ends up in and of itself, for example, really helping the system lead to sort of autophagy, and in the brain, mitophagy, and clear out old little mitochondria that could get you in trouble if they're hanging around too long, is really striking, because it may be what's responsible for improvements in cognitive functioning, even in people who have early decline. It may be what's responsible, that mitophagy, autophagy process that we see, for things that I don't think we can attribute to GLP-1s now. And, I'm not the expert on GLP-1s, I have to say, not the expert on them. But when I look at what I rather work with someone, even somebody who's struggling, to say, can I help you get ketogenic? Can I help you see the benefits, all of the different benefits from a ketogenic lifestyle and all of the metabolic health that comes from it, instead of a GLP-1? I'd rather do this, because this, I know, we've seen over years, is benefit that lasts and benefit that stays, benefit that no insurance company can take away, because they take away your medicine. Benefit that doesn't reverse because, oops, you're traveling and you forgot your GLP-1 somewhere and your doctor's not available. So this is ultimately, I think, going to move people towards real metabolic health, real brain health, and real improvement in brain functioning in a way that we haven't seen. You're right when you said the epilepsy world has seen it. They've seen striking improvements, and they have the research that now I think we have to develop in psychiatry or across fields to show.
Yeah. And, on the research front, again, very exciting times, because most people probably won't be aware of, you alluded to it earlier, how much research is ongoing now into this. And thankfully, there have been some, very generous people funding that. There's been a huge grant from the Bazuki family and others that are funding this research, which again is kind of groundbreaking, to have research like this, because the traditional barrier to this type of research is, there's no way to monetize it at the end, right? There's no pharmaceutical company that can, make profits off of it. So it was always like, okay, where's the money going to come from? And thankfully, the metabolic psychiatry world, it now has good funding, and there are a lot of high level projects going on. Maybe talk a little bit about that.
I'm really excited to be part of that whole world, to be a clinical advisor to the Bazuki group and to be associated with Metabolic Mind and what they're doing, because single-handedly, they have turned their own search for knowledge to really help a family member into making it available, making knowledge available and easy. by video, by Zoom, by podcasts, by all sorts of means to anybody who's looking. It used to be so hard to find somebody who knew what to do. Charlie's story with the Charlie Foundation is like a perfect example of that. But the Bouzouki group, with what they've done, is like something I've never seen in any other branch of medicine, because they're funding trials on all kinds of levels. They're funding researchers around the world. They bring us together, clinicians and researchers, regularly to talk about what we're seeing, to look at the different signals, to try to find out the best biomarkers that we should be following in future studies, to really talk about early research results. That is fertile ground for just ideas exploding, and then more studies. And the idea, I hope, is for the rest of the world to say, oh, we're now seeing early studies. We need to fund this too. NIMH needs to get on this. Other countries need to get their general governmental funding sources on this. Private, corporations need to get interested in this, because it moves health forward.
This is fascinating and exciting to me as somebody who is not remotely educated or particularly smart about the field of psychiatric medicine. In the interest of full disclosure, I have been deeply distrustful of psychiatry in particular. And I think the reasons are fairly common, mostly because it seems like, let's just throw drugs at it and see what happens. It's felt like it's been a shotgun approach to fixing things.
Mm-hmm.
The idea that the metabolic health and the what are considered psychiatric, diagnosable, quantifiable psychiatric malfunctioning, can I use that word? That those two can not only be fixed with the same approach, but in fact might simply be different manifestations of the same root problem. I mean, that's phenomenally exciting. I don't have a question here, do I? I'm really just kind of commenting. I'm aware of that. But still, for a layperson, yeah.
You're catching my excitement. Like, you're catching my excitement. This is what makes people get out of their silos. We need to get, in psychiatry, we need to get out of our silo. We need to publish in different places. We need to go to meetings like the Society of Metabolic Health. We need the Symposium for Metabolic Health that SMHP put on. We need to really, I think, be more available to the knowledge that is popping up in different journals and in different fields, just like I think other fields are interested in what we're doing too. And so I think for that reason, it was really exciting for me to come with a case report that was a cardiology case report to that meeting and say, wow, isn't this cool? And don't people want to learn about this?
Yeah, no, and I had commented on exactly that at the meeting, that, none of the meetings that I had gone to prior to getting involved in the metabolic health space, did I ever really interact with other specialties, right? They were always cardiac focused, and nothing that I really can think of from a, cardiac standpoint, right, in terms of the treatments we would use, really applied outside of the cardiovascular world, right? We didn't have something like, oh, I'm doing this and it's improving heart disease. And oh, by the way, it also might make psychiatric conditions better. That was just unfathomable, quite honestly. And, it's the whole reason that the medical system sort of evolved the way that it has, right? That we became, we all got siloed into our specialty because there wasn't really a lot of crosstalk between the specialties. And that's something else that's really just groundbreaking and exciting to see, than to be at a meeting where, we have cardiac physicians, psychiatric conditions, we had a number of different, other specialties, kidney specialists, and, the diabetes and obesity specialists and the internal medicine generalists. And we're all there seeing how our experiences are all overlapping.
Yeah.
Oh boy.
Fascinating stuff. Maybe talk a little bit about what this looks like in your practice now. You kind of alluded to you have this part of your practice, right, that's focused on this. And you are in, community practice, like you said. You're not, in an academic center just sort of researching this. You're seeing it every day. So what does that look like now in your practice? And, how is that different than perhaps what your practice was like, 10 years ago?
So it's completely different. 10 years ago, my practice was me. It was me seeing people in the office all day long and figuring out. Sometimes I would do psychotherapy if that was appropriate. Sometimes it was medication, but it was trying to stay abreast of what was new and always wanting to look at what could I be doing more? What could I be doing better? And really realizing, and when all the data came out, that the majority of people I treated stayed with me because they needed to, or they might have gone to somebody else, but they stayed in treatment because they needed to. So it was very cutting edge until it wasn't cutting edge anymore, until I started realizing every medicine is like another medicine. There isn't really anything new coming out. There isn't anything new enough coming out. And the best that I can do is to give people medicine to the best of my ability, give them psychotherapy or refer them to a psychotherapist, and add more treatment and add more treatment and add more treatment. Then some new things came out, and I was interested in all those new things because I'm interested in staying on the cutting edge. And now my practice is very different. Now it's got a different name. It's not called Lori Calabrese, MD. It's not my name. It's called Touchpoints 180. And that's because we use dozens, hundreds maybe, of different kinds of touch points. And the idea is to get people to do a 180. So when they come to see me, they don't get just me. We look at whether or not they are interested, ready, willing, appropriate for adding a metabolic therapy to what they're doing or replacing what they're doing with what we have to offer. And then we go to work to individualize a whole pathway for them with dietitian coaching, interventions, workshops, a book club, meditation groups, all of these different things, nature walks, forest bathing. The things that we are putting together are
forest bathing.
Forest bathing. That is coming up on our next scheduled event, because it's not just a walk in nature anymore. It's really about very intentionally spending time quietly in a forest. And
Okay.
and
We're
for all
not
of the
talking
benefits
about taking
that
a
does.
tub of water and
Oh, no.
scrubbing
No, I'm not talking
yourself
about taking
under
a
the
bath.
trees.
No.
Okay.
I'm sort of talking about really, really doing things that are levers that really move the needle for you. And so that means other metabolic treatments as well that involve circadian rhythm, and strategies that we use depending on what the person needs to really get as well as they want to be. So the idea is figuring out, if you come to see me, what is it that you want? What is it that you're looking for? For some people, it's, I want to lose 60 pounds and get rid of my diabetes and get rid of my belly fat and stop my antihypertension and stop my statins. And I'll say, okay, let's look at that and let's see what gets better along the way. And then if I need help along the way, I'll pull in consultation. But we do things like take people off their diabetic medicines and get them off their statins when it's appropriate. And complicated things like taper their antihypertensives as they get better and better. We do all of that. We need to do all of that. And so I needed a lot more training, right, than I ever had as a psychiatrist to be able to do this well. So we manage the gamut of things, and we see people with all kinds of inflammatory conditions, from ulcerative colitis to rheumatoid to other things. We manage both the body and what's going on psychiatrically, and figure out with people what that's going to look like over time, help them over time, and then coordinate with whoever else is out there over time that they might need specialty help with. And often that's coordinating with their primary care doctor who doesn't know much about this, or sometimes coordinating with outpatient psychiatrists in places who are interested but, are unfamiliar.
Yeah.
Yeah.
That makes sense. You brought it up twice, which is why I'm going to go back to it. Ulcerative colitis. The only reason I even know about that is because my dad allegedly suffered from it. He's gone now. He's been gone for 10 years. It appears, based on what I've heard you say, and also from my experience with my dad, that what I guess would be termed psychological problems or psychiatric problems are related to gut health, ulcerative colitis maybe being one of those. Could you kind of dive deeper on that?
Yeah, let me go back. There is an absolute gut-brain connection that we've known about for a long time. Just there's a cardiovascular brain connection. Panic disorder is a perfect example of that, right? The gut-brain connection is mediated in a very complicated way by signals that happen at the level of the gut cells and travel through the body through inflammatory pathways. So there are many different types of GI issues, from irritable bowel syndrome to inflammatory conditions that turn on inflammatory cytokines in the rest of the system. And those inflammatory cytokines have multiple downstream effects. We think that one of those downstream effects has to do with whether or not they are loud enough to get past the blood-brain barrier and into the brain, and
Okay.
then turn on a kind of neuroinflammation in the brain that cycles in very specific ways to be associated with panic, with anxiety, with
Huh.
OCD. Now, part of this is looking at this from a, basic science perspective and needing to clarify that more. And part of it is just the clinical stuff that we see
Yeah.
every day in the rooms, in the offices that we inhabit, where we see people who say, yes, when I'm stressed, this gets worse. Yes, when I'm stressed, my Crohn's disease gets worse. No one is saying stress causes Crohn's disease, or Crohn's disease is the cause of stress, because making those big causative statements is really difficult to prove. But when
Right.
we look at how connected they are, and when we look at the fact that something can actually quiet the symptoms in another part of the body at the same time that it quiets what is going on in the brain, putting that together, I think, is where the next frontier of research is going to go. We're going to really be able to understand that much more clearly when the big academics tease it apart.
Let me summarize what I'm hearing. And this is not just from you, this is from Dr. Georgia Ede and Chris Palmer.
Yeah.
What I'm hearing is that what those of us lay people who aren't inside medicine have perceived as an entirely separate realm of medical practice, stuff that has to do with your thoughts, your emotions, your brain, are all actually the same systems not behaving appropriately, and the same thing that can fix your diabetes. And I realize I'm not using clinically recognized terms here. This is a layperson talking. The stuff that can fix your diabetes can also fix your wacky thinking because they're just two different manifestations of the same root problem. That's what I'm hearing.
So let me just change it around a little bit and say the stuff that can heal your mitochondria can heal that mitochondria in multiple different cells in your body. Okay.
Oh
So,
yeah, and that's a
so,
much more
so,
understandable way to
yeah.
express it than I.
So the stuff that, so when I think about, wow, if I'm running on better fuel, different fuel, all of a sudden things are so much more clear here. Guess what I just talked to somebody about this morning? Just this morning, because I was doing a lab review with one of my metabolic patients, practice members. Her GFR increased.
What's that?
That is the glomerular filtration rate. She's working
Okay.
with us. She never had a problem with it before. She doesn't even have a kidney issue. She's got other stuff. And as I'm looking at her follow-up labs, I say, I just want to point this out to you. Do you know it's not because you're drinking more water? It's because actually because you could drink all the water you want and your filtration rate could still be poor because you're heading towards kidney trouble. This improved your kidney function. Do you understand? This is so broad like that. And I think it's why when people get afraid of metabolic therapies, ketogenic eating, ketogenic treatment, they get afraid because they start seeing things that their doctor sees on a lab that the doctor can't explain or that the doctor gets worried about. Phil, you probably see this all the time because people come to you with elevated lipids. And
Yeah.
yeah. And so the young woman that I presented at the conference was a young woman who came to me because she had been doing okay. She had been on psychiatric medicine for about 10 years. She was diagnosed with, she had episodes of mania, depression, psychosis. She was diagnosed with schizophrenia, but had panic and anxiety and bulimia and all kinds of things along the way. When she came to me, she had come to me on a psychiatric medicine that's really associated with elevating cholesterol. And her doctor had said, yeah, you have some elevated cholesterol. You've had it for 10 years. Okay. And it was, or 7 year, however long the cholesterol had been elevated, but for a while. And it was attributed to the medicine. And when she came to me, she said, I liked this medicine. It makes me so tired. It makes me so drowsy. I don't like it. I slur. I want to get off of it. I heard that I could do really well. So the quick story is, as we began a ketogenic therapy for her, brain sharpened up. We were able to taper her medicine. Metabolically, she went from unwell to really excellent metabolic health. And what happened was, as that happened, she got better and better. All of the insulin normalized, all the things that Phil knows about, got beautiful, and her cholesterol started climbing. And as her cholesterol started climbing, everyone around her said, oh, wait a minute. Oh, wait a minute. Isn't this dangerous? Isn't this because of your diet? Isn't this because of what you're eating? And the beautiful part of this story that Phil is going to help her with is really that when you evaluate all of that and we looked at it, we actually, in somebody who's 29, got a calcium score 0. Her coronary artery calcium score was 0. She's at this perfect point of inflection to say, I'm so well, I'm so much better. I'm on less medicine. I'm on my way to getting off. None of my symptoms have come back. None of the stuff that had plagued me had come back. I'm so metabolically healthy. I never want to give this up. Like, I never want to give up what I'm doing in this way of eating. Do I have to give it up? And the world around her will say, yeah, look at how high your cholesterol is.
Your cholesterol number, right?
Yeah.
Yeah.
Your LDL, right? Yeah.
Yeah, it's really, just sort of crazy, at this point that physicians, right, can't understand the different context, right? And that's really what we're getting at here, right? We're trying to change the whole context, the whole paradigm around how we manage health in general. And, things, some of these lab numbers that might mean something in one context don't mean the same thing in this different context. And that's really the challenge that, you and I and all the other practitioners that are in this metabolic health space are facing, is that our colleagues who are not just can't understand that, this is a completely different context that we need to be looking at all of this in. The research that you're doing is really helping that. And all of the great work that's going on, in the Society of Metabolic Health, in Metabolic Mind, this is what ultimately is going to move us forward as the profession of medicine, right? It's not just about, a couple of, quack doctors like you and I that are out there, trying to do things differently. Awesome. I know people are going to be interested in, your work and, trying to contact you and everything. Let people know how they can do that.
They can reach out to me at touchpoints180.org. It's touchpoints with an S, 180.org. That's the easiest way to learn about our practice, to schedule a call with me and to move forward and see if working together makes sense. They can call my office as well, and I can give you that office number if you'd like it. Either way is fine.
Yeah, let's stick with URLs. In the age of AI, we don't need bots calling your office because you
That's right.
said your number this way.
That's right.
All right. Lori, thanks so much. You explained some things in a way that made it clear to me where it's maybe I've been a little bit fuzzy, and I appreciate that. Our guest has been Dr. Lori Calabrese. Touchpoints180.com is her URL.
.org.
I'm sorry, .org. Ooh,
Yeah.
touchpoints180.org. That's important. That information will be in the show notes. Thanks for joining us. For Dr. Philip Ovadia, this has been Stay Off My Operating Table. We'll talk to y'all next time.
Thank you. Thank you so much. It was a pleasure.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.